Okay. And the winner is. Oh, it's split down the middle. All right. So this is interesting because half the class is thinking it's cubital fossa, the half think it's arcadophosis. So this is the pinch test. We talked about that before. What's the nerve? Median nerve. More specifically, which one? Anterior, posterior? Anterior. It's okay. So posterior is this one. Anterior is this one. Okay. So radial nerve and posterior, interosseous nerve. Anterior interosseous nerve off the median nerve. So that's the first thing you need to figure. So that's the median nerve. Second question is, okay, so which one of these is related to the median nerve? Funny bone, what's that related to? Ulnar. That's in the cubital tunnel. Arcadus struthers, what's that one? Ulnar, where's that again? Medial intramuscular septum, that's up high, that's your ulnar nerve. Anterior wrist, what could that be? Now again, that's a generic term like this. Anterior wrist, more specifically. Ulnar, no. Median, because of what space? Sorry? Carpal tunnel. So this could have been an answer as well. If that's the way you rationalize. Anterior wrist, carpal tunnel, median nerve, which is related to the pinch test. Okay. Now, arcadophosis, what muscle is that located in? Supinator or supinator? Supinator, which is the radial nerve. Radial nerve innervates the hypothenar because of the posterior interosseous nerve. The pinch test is anterior interosseous nerve, so this is incorrect. Is cubital fossa correct? Where is the cubital fossa? It's that triangle in the front of your elbow. Pronator teres, brachioradialis, and then you can say the crease or biceps tendon as this border. But it's the brachial artery and the median nerve that go through the cubital fossa. Okay, so again, there were two correct answers. This one would be the more obvious correct answer. And this one, if you are suggesting, or if you're referring to the carpal tunnel, then that's the right answer as well. Okay. Arcadophosis is in the supinator, where the radial nerve pierces that muscle. Okay. Now, you can technically modify your pinch test by doing this. And then you can say that that's the right answer, because now you're using hypothenar. Thenar, anterior or posterior? Anterior interosseous nerve. Hypothenar is the posterior interosseous nerve. This one is radial, this one is median. So does that make sense? So we do have a couple more of those that are coming up, but let's get to the pathology for the wrist and the hands and the fingers. Sorry. Anterior interosseous nerve is the median, which is the arm, and then the posterior. Sorry. Actually, I apologize. Our anatomical models are in need of fixing. So I'm putting the models out in front of you so you can share it between the people close to you. Because a lot of these conditions, it's better to actually have them all in front of you, so you kind of have an idea of where we're coming from when we talk about some of these pathologies. So fractures, dislocations, sprains, strains, so this is the list of stuff we'll talk about in the wrist. There's another list for the hand and some for the fingers as well. So the first one we'll talk about is a Colles fracture, Colles. Distal radial ulnar fracture. If it's displaced dorsally, it's a silver fork. If it's displaced palmarly, to Smith's fracture. The dorsally and the palmarly, that's the radius and ulna. So if the radius and ulna is displaced dorsally, it's a silver fork. So dorsally, this is palmarly, okay, where that is displaced towards the palm, and then vice versa for the other way. Okay. The main thing with a Colles fracture from a management standpoint is check PMS. Now, are you going to know if it's a fracture or dislocation? You might. I'd probably say that a squeeze test or a compression test will still be painful if it's a dislocation. So it's hard to tell. The one way you can tell is if the patient actually says, I heard a pop versus I heard a crack or a snap. Okay, but we all know that people confuse those, or they just use those words differently as well. Some people might think a snap is a pop and vice versa, so it might still be difficult. Sorry, Brent.
So going back to the field, but if you see something like that, would you actually still want to squeeze?
No.
Okay.
What pulse would you do the snap box or cap refill, or?
That's a good question. You may not be able to get to the radial pulse on this one, so cap refill or anatomical snuff box might be better options if you can't get a pulse on the anterior surface. Okay, so those are good questions, because again, if you do get this, you do want to check PMS. Pulse might be challenging, like Neil said, because radial pulse might be hard to get to. You might just check circulation or cap refill, or check the pulse in the anatomical snuff box. Like Brent said, if you see an obvious deformity, I think I mentioned this to some of you guys during your practical exams as well. If you see something like that, don't do a fracture test. The reason why you do special tests is so it gives you an idea of what you need to do later on. Is confirming a fracture test with this going to change what you do at all? What would you do in this particular case? You see this one. You see this. What are you going to do anyways? You're going to splint it and ship. Tape them up. Go. You got to be natural now. Let me see my hands. Okay, so it's not going to change what you're going to do or how you're going to manage this, so there's no need to further test if you see this. Okay? So signs and symptoms, deformity, shard, and then neural and circulation. Again, confirm that those are good. If circulation is not there, it becomes a limb-threatening emergency, which means you have to call EMS. I think most people would call EMS for that anyways. Okay. Can you certainly split this and then ship them to urgent care? You probably can. You probably can.
What if they start to lose like circulation on the way to the hospital?
See, that's not good. Yeah. So, could they go in a car and go to urgent care? They could. I would recommend you call EMS. I think for those of you who have seen this at wrestling already, I think the parents would rather you call EMS. I think a lot of people feel safer if you call EMS for something like this. Okay, the next one is a scaphoid fracture. Scaphoid. It's usually what the type of fracture you'll find in the wrist. If you guys take a look at the models, it should be fairly easy to figure out where the scaphoid is. It's normally a result of fouche and radial deviation. If you abduct at the wrist, abduct, or radial deviate, same thing, hopefully you can see that the scaphoid will be compressed. That is also a special test, or a way to confirm a scaphoid fracture. Pain in the snuff box, we talked about that before. The other thing you could try doing is compressing the first metacarpal towards the scaphoid. So you're essentially doing an axial load where you take the thumb, not so much the phalanx, but you take the metacarpal itself, so below this, above, I should not even say that, proximal to your MCP joint, grab the metacarpal and drive it towards the radius. Recognize that it's pushing on the trapezium, it's the trapezium that's pushing on the scaphoid. Okay? So that's a compression test as well, it's an axial load, and you can confirm problems with the scaphoid that way as well. Complications. Now I talked about this the other day. This is the complication of avascular necrosis. In this particular case, with the arrow is, that's your scaphoid, and that's a vascular necrosis. It's starting to degenerate. In a small in a small portion of the population, just one of these ends is actually innervated by by an artery. So it has blood flow to one end and not the other. And the minute it's fractured down the middle, the opposite end is not going to get nourished. Okay, so it'll eventually die. I'm not sure if you guys have talked about this at your placement sites, but those of you who have had scaphoid fractures, I think there have been a couple that I've read in your log books, that you're not going to pick it up right away on an x-ray. So your clinical exam is a little bit more accurate than the x-ray on the initial examination. Okay, because it's just too hard to see on an image, and they normally don't pick it up until later on when it starts to heal. Have you guys talked about soft and hard callus healing, bone healing? No? Okay. Have you ever gone through long bone healing and what it looks like on an x-ray? Or like stress fractures? I think I even posted that when we talked about lower leg stress fractures and shin splints. Is that you know that there was a stress fracture when you get an x-ray 3 or 4 weeks down the road with healing, because you'll see this huge bump in the middle of the bone. And that's the site where healing has taken place and is now formed from a soft callus to a hard callus. And that you'll pick up on an x-ray. But when you first get the x-ray from a stress fracture, you won't see anything. It'll just look like a normal bone. Okay, like all their symptoms will come into clinic. You can poke on it, they'll give you their history, but you won't be able to see it on an image. It's not until 3 or 4 weeks later you'll see this, like you take a pre and a post image, and you'll see the difference. And the difference is this callus formation where a fracture was. Okay, so that's what you might see with a scaphoid fracture, or you might see avascular necrosis on an image later on down the road. Okay. So again, a scaphoid fracture is probably the most common in the wrist. The other bone that's potentially fractured is the hamate, because it has a projection called the Avoca Headache. So if you look on the models, if you can find the hamate on the model, okay, there should be a little projection there. You can palpate it on yourself, and it's just north or distal to the pisiform. The pisiform is that bone on the medial side of your wrist. A lot of people that do manual therapy use that to feel around with. Okay. This is typically used to help with mobilizations too, when you're doing a mold, like a PA on one of your vertebra. And so that's the pisiform. If you go just distal to that, the hook of the hamate is embedded in there. In most people, you can't really, it's not as distinctive as the pisiform. Okay, but it's adjacent to it. So you're in and around the same area where the hook of the hamate is. If you have a Fuchs mechanism or a repetitive mechanism that puts a lot of force where the pisiform is, then potentially you could be irritating not only the hook of the hamate, but the structures that go through what's called the tunnel of Guyon. Okay. Again, the tunnel of Guyon. Which nerve goes through the tunnel of Guyon? Ulnar nerve. Okay. Pain over hypothenar evidence, hook of the hamate, and then unable to perform twisting motions. So if someone does complain of this and you're suspecting, well, the pain's there and therefore you suspect hook of the hamate issues, for them twisting their hand like this, it'll just accentuate the pain and potentially the neural symptoms for the ulnar nerve. Okay, so that's what that might be. Okay. Any questions about scaphoid or hamate fractures? Okay, those are the most common fractures. We'll talk about other carpal bone dislocations later on. Generally in the wrist. So remember the silver fork deformity, the Colles Fracture picture? They kind of look similar. Oh, okay. That's a friend of mine. That's Kelly. That's University of Florida Gators. That's her. Sorry. Yeah, there's a hierarchy with at the University of Florida. If you wear orange, that means you're in first year. If you wear blue, that means you're a GA or a graduate assistant. You're a supervisor, and if you are white, you're an undergrad. Yeah. So, anyways, that looks similar to a silver fork deformity. So again, it's kind of hard to tell if it's fractured or dislocated because they look pretty similar. Same situation though, check PMS. There is no need to do a fracture test on this. Again, don't just start squeezing away or tapping or anything like that, because again, it's not going to change what you do. Just immobilize the position found and send to the hospital right away. A lunate dislocation. Okay, so it's going to be helpful if you actually have a model of the hand in front of you, and if not, if you want to Google an image of the skeleton of the hand on your laptops, then you can do that as well, just to give you an idea of what we're talking about. So lunate dislocation. How do you find the lunate? How many of you guys bought Trail Guide, by the way? Okay, so that's a fantastic book. At the end of these at the end of the anatomy presentation and the assessment presentation, I took a lot of slides or pictures out of Trail Guide and put it in to give you an idea of how to landmark some of these carpal bones. The lunate. So if you flex your wrist like this, right? So on the dorsal aspect, there's a little hole like right in there. You should be able to feel it. And then when you extend, it disappears. Okay, but that's where your lunate sits, generally. It's just a soft spot on the back of your hand. Okay. So if you put your finger there and take your thumb and draw a line between your thumb and your finger, and you do this, technically you can try to feel how well the lunate moves. Okay, and that's the one right beside the scaphoid. Scaphoid, lunate, tricuspid, pisiform. Okay, that's your proximal row. Okay, again, if you need to use the models, use the models, because that'll definitely help paint this picture for you. So there's two types of things to look out for. Both are caused by forced hyperextension. One is called a scapholunate dissociation. Capitate driven between the scaphoid and the lunate, and then the lunate displaces palmarly. Okay, so let's take the first one, forced hyperextension, so foosh, right? You do this, you go like this. The capitate is more distal. Okay, so you got scaphoid and lunate with your, like in the proximal row, and then trapezoid, trapezium, capitate in the distal row. If you hyperextend, the capitate comes back this way and hits the lunate. Right? So when you hyperextend, it's like the proximal row, the distal row, when you hyperextend, comes back like this, pushes up against the lunate. So when you go like this, capitate comes up and back and hits the lunate. So that's what that means. Capitate driven between the scaphoid and the lunate. And as a result, if this happens, okay, so if I'm standing in anatomical position, if I push my hand back, right, the capitate moves this way and then pushes the lunate forward. Pushes the lunate towards the palm. Okay, now if that happens, it's referred to as scapholunate dissociation because there's 2 or 3 ligaments that hold the scaphoid and the lunate together. Again, I told you you're not responsible for knowing all those little ligaments between the carpal bones, but there's little movement between the scaphoid and the lunate, generally. There's supposed to be very little movement. If this happens, you can stretch the ligaments between those 2 carpal bones, which means that these now become dissociated. They don't function as one. They should function as one, but the capitate could drive the lunate away from the scaphoid, and then there's excess movement. That leads to arthritic conditions later on. If that happens, what they tend to do is they pin it together, which I don't think is a great idea either, but it prevents excessive movement. So that's what scapholunate dissociation is. How do you pick that up? We'll talk about how you can take the lunate and see how mobile it is relative to the scaphoid. Okay, and then compare bilaterally. The other one is called a perilunate dislocation. The volar ligaments ruptured between the scaphoid and the lunate, and then the lunate is displaced dorsally. I'll actually show you a picture after the break, which I can try drawing it. Okay, so a good way, I'll do my best. That's the radius. That's the lunate. And that's the capitate. perilunate dislocation. So this is the hand, and that's the palm, and that's the dorsal side. I'll draw fingernails. Does that help? So my hand's like this. I love the looks on your faces right now. Okay, so radius, lunate, capitate, and then we have our metacarpals and phalanges and so on. Sorry, my fingers here should be longer. But we're just looking at the capitate and the lunate right now. Okay? So this is not normal. Okay? It should be sitting, so they call the lunate the teacup. It should be sitting like that. Okay, that's normal. With a scapholunate dissociation, you could potentially run into this issue. Okay? And then this loosens between the lunate and the scaphoid, so they become dissociated. But you could end up with a capitate that's dislocated as well. A perilunate dislocation happens when this occurs, but as this occurs, just the fact that this falls over and the more hyperextension that occurs, it'll drive this forward. I don't know if you guys can visualize that. So normal extension, ow, that hurts. And then if you really force it, it'll knock this thing off the radius. So you'll end up with something that looks like this, where the teacup is there and the capitate is there. Sorry, that's kind of exaggerated. But it's not sitting on the radius anymore. Okay. This requires a lot of force. These are rare. You'll end up with this usually, but if you force hyperextension, it'll look deformed. There'll be an obvious deformity with the wrist, and it'll be locked. It'll be very painful, but it'll push the lunate right off the radius. Okay? And that requires pinning. That requires surgery and rehab and so on and so forth. So, I mean, that's a situation where if the lunate, it moves off the radius, it could potentially move into other spaces like the carpal tunnel. Okay, if it moves into the carpal tunnel, then potentially it'll put pressure on.
Would it be the other way for dorsal?
Yeah, you're right. Dorsal's backwards, so that should be anterior. Let me confirm that with you. I'll look at Schultz again, because I thought maybe he said something different. Okay, but I'll confirm that with you. But the main idea is the lunate is no longer sitting on top of here. Okay. So this is a dissociation, and this is a perilunate dislocation. Okay. Peri just means nearby. So if you see that prefix, it just means nearby or close to, in proximity. So perilunate dislocation means that the lunate has been dislocated to an area nearby where it should be.
Would you ever have it dislocate to an area that's not near?
Usually it's in a space. And so again, that's why I was thinking it was anterior, because that's where the carpal tunnel is. If this place is dorsally, you'll see a bigger bump on the dorsal side of your wrist. Like, was your question, will it ever go elsewhere? No. Because of all the other bones around it? Okay. It'll either go forward or back. Okay. Now again, how you figure that out, you just feel the little thing in the back of the wrist, where it's supposed to be, compare bilateral and see where it is relative to the opposite side. It is common to get carpal tunnel symptoms with these. Okay, because again, if the lunate's not sitting where it's supposed to, it could potentially put pressure in the carpal tunnel. Lunate dislocation. Pain along the radial side. So there's a picture. I found a different picture. And I'll see if I can bring that other picture up for you. Bulge proximal to third metacarpal crepitus, median nerve paresthesia, and possible scaphoid fracture as well. So that we did talk about some of those things, how carpal tunnel symptoms could arise out of this. The bulge proximal to the third metacarpal, so you might get the bulge anteriorly or posteriorly, depending which way it goes. Murphy sign, you guys can do this right now, just make a fist. And if you look at your third knuckle, the third metacarpal, typically it should project a little bit more distally. It should be taller. Murphy sign is where it actually sits lower and it looks pretty flat over your knuckles. So if you look at both, if you have the person do this, the one knuckle will be sunken compared to the uninvolved side. Okay, that's Murphy sign.
And that means lunate.
It means lunate dislocation. It could also mean a metacarpal fracture. It could also mean a cavitate dislocation. So it can mean different things. Okay, but if you look at the models, anything that has to do with that middle knuckle, metacarpal, if you keep going proximally, cavitate, and then lunate. Okay, so anything along that line of the third metacarpal, that's what Murphy sign could be positive for.
Can you fracture your lunate?
Sorry?
Can you fracture your lunate?
Your lunate? I'm sure it's possible. Probably not with foosh, with an extension or flexion, but maybe with an axial lobe, so punching. Usually, if you punch, if it's going to break anything, it'll break your metacarpals, not your carpals. Any questions about fractures or dislocations? Wrist sprains. I put this picture up before. Those are all the ligaments that are involved. This is the lunate. And as you can see, there's all these ligaments that hold the lunate in place. Okay? So it's not supposed to move very much. Again, with forced hyperextension, if you have a lunate dislocation or a scaphoid lunate dislocation, it'll drive the lunate away from the scaphoid, and that lunate will be able to move far more than it should, causing premature arthritis, and that's not what you want. Okay, but that's why all these ligaments are there, to prevent that from happening. Wrist sprains narrow based on exclusion of other injuries. Radiocollateral ligament sprains associated fracture dislocations. So if you have an RCL sprain, again that's this side. Okay, so an RCL sprain is caused by forced ulnar deviation or wrist adduction. Then you might want to consider a fracture or dislocation as well and rule those out. And these are the different types of mechanisms that can cause a wrist sprain. I don't think there's anything too crazy here that needs explanation other than these are two different tests I don't think we've gone through. Valgus varus doesn't really change. Again, it's just another joint with collateral ligaments, so you can do valgus varus or the wrist. Wrist glides, again, that's the concave convex rule. So you can do just glides to assess whether or not a ligament is involved, but the way you tell is where they complain of pain. So if you do a traction or a glide, if they point to the ligament, obviously that's the ligament that's been damaged. The lunato-triquetral allotment test, that's the one where I was talking about you can do this and then you just move it. Okay, it's just a glide, if you will, of the lunate relative to the other carpal bones around it. Okay, but again, we'll get to this when we practice special tests. TFCC, this is the triangular fibrocartilage complex. Again, at the end of the ulna, we talked about what this structure is for. How it presents, it's associated with an ulnar collateral ligament sprain. Can you get this?